Now we move on to our panel discussion, where we're going to be talking about the coronavirus and how it's crippled an already broken health system in Syria. For this discussion today, we have with us Dr. Ola Abara, consultant in infectious diseases, Imperial College, NHS, Dr. Fuad, associate professor at American University of Beirut and co-chair of Syria Public Health Network, Mandar Marzouk, public health researcher and consultant, Dr. Nasir Mawesh, public health specialist and surveillance coordinator for the Early Warning Alert and Response Network of the Assistance Coordination Unit. And moderating this session, we have with us Crystal Van Leeuwen, Medical Emergency Manager, OCA, MSF. Thank you for joining us all today.
Thank you.
Thank you.
Excellent. So I think I'll be moderating this session, and I'd like to thank everyone for joining us, and also MSF India for inviting us to speak on such an important topic. What I'd like to do is introduce our panel in more depth. So I'm going to start by introducing Dr. Fuad. So he's an associate professor at the American University in Beirut. He's a general surgeon from Syria, and he's also a researcher who's done extensive work in Syria and the region, which is pertinent to the discussion today. We have Crystal Van Leeuwen with us. She's a registered nurse who holds a master's in public health, and since 2012 she's been working in various emergencies, including Syria. And she's now the medical emergency manager in MSF headquarters, with experience particularly of northeast Syria. We've got Dr. Nasir Mawesh with us. He's a general surgeon by training from Syria, and he's also been working in the EWARN, the Early Warning and Response Network surveillance system across Syria, and we'll be hearing more from him about this. And he also holds an MPH. And Mandar Marzouk. So Mandar is a Syrian global health researcher who's also worked in the humanitarian context in Syria. She's recently been working with the COMO initiative, that's the COVID International Modelling Consortium, which is a collaboration between Oxford University and Cornell University. And she's been doing some modelling both in northwest and northeastern Syria. I'm extremely excited to welcome our panel today, and we'll be exploring the situation with regards to COVID-19 across Syria. So I'm going to start with some questions to the panel. So I think for the first 15 to 20 minutes, I'll direct some questions to our panel. And then there'll be about 15 minutes or so where the wider community can ask questions of our expert panel. So Dr. Fuad, can I start for the first question for you? Obviously, Syria is a protracted conflict now. Could you give us an overview of what the conflict has done to the health system and how this has affected the COVID-19 response? And I know that you have a slide, but perhaps if you start talking, we can see if we can pop the slide up for you.
Thank you very much, Ola, and I would like to thank the organizers for inviting me to this very important event. And I see this is a great opportunity to bring the question of Syria, not just as a isolated problem, but it's definitely now after 10 years of the conflict, it is a global issue. Thank you, Ola. I don't know if you can share the map of from your side, or should I do that? You can do. Okay, thank you very much. So just I want to set the scene for the discussion, and definitely we can talk later. Syria is a sort of in West Asia, close to Turkey, is a country of 185,000 square kilometer, and till 2011 it was like a sort of one health system model, given that we're talking about one territory. During the armed conflict, or this crisis that started as a peaceful demonstration, ended up to be devastating, actually, and very bloody armed conflict. The territories, the land territories, divided by time and controlled by different powers. And I would like to see the map, Ola, if you allow me to, just to show how that these territories actually also change by time. And what we see is
it's about to go on. If I can share the screen, there we go.
okay, wonderful. Okay. Wow, wonderful, thank you.
There we go.
So what we see is that we're talking about now a land that divided by different actually powers, and some of them are just like an unpowered or non-state actors, but also it's not the issue of internal power. There's a sort of intervention from different external powers. To name some are the US, Russia, Iran, Saudi Arabia, Turkey, so many international powers. And that ended up with this sort of map where we see the yellow is where now the government or what Syria regime controlled area. The one in pink this is like a rebel areas in northwest and in the south close to Jordan and Iraq. And there's a spot in the middle here where the ISIS-controlled area, that what was one day is sort of controlling half of Syria and portion part in Iraq. So now it's controlling a small part here. There's an area of the Kurdish-controlled area with support from the US forces. There's a Turkish-controlled area in the west and northeast, and of course, we have here where the historical Israeli-controlled area. So Syria divided and now divided into de facto fragmented territories. And therefore, and that's by sort of consequence of that, the health system divided among these different territories. And this health system that, for example, in the controlled area, still in the old health system, we have now a different or parallel other health system, like in the north or west, that depends mainly on NGOs and international organizations that support the health services, whereas we see the model in the Turkish area is completely different, that there is a sort of mix of the self-administration with strangely that some main cities here still the staff get some salaries from the government here, where we have here in north and northwest, in the north actually, still we have sort of support from the Turkish government. Mainly, the main feature for all territories are the lack of staffing. There's a sort of lack of resources, and there's a sort of lack of training. If we can go back in the course of the Syria crisis, the main feature was the weaponization of healthcare, and that actually affected the health services, where the government, mainly 95% of the attack happened by the government forces and its allies, mainly Russia and Iran, attacking the health facilities and deliberately, arresting health workers for offering services. Just to give number from the Physicians for Human Rights, between 2011 and 2018, that's the last data available, almost 1,379 attacks on health facilities, on almost like 500 health facilities in Syria. Some of them were attacked 13 times. And this is a main evidence about this sort of intentionally attacking the system. What happened, of as a consequence of these attacks, that many of the population living in these areas of hot zone areas left this spot to other part, and that create a sort of a bit demographic change inside Syria. I think I will stop here, Dr. Ola, and come back later to see if we can talk more about what's the impact on the of this on the COVID care. Thank you.
Fantastic. Thank you very much, Dr. Fouad. That's a brilliant overview of a very complex situation. So I think you're saying that the health system is fragmented. There's more than one subnational health system across Syria, and that has affected potentially the COVID-19 response. So Crystal, I'd like to direct my next question to you. So you've been working in northeast Syria, and as some of our community who are listening in today will know, there was the closure of Yarubiya border crossing earlier this year. Could you tell us a little bit about the COVID-19 situation in northeast Syria, and maybe touching on whether the border closure has had any impact?
Yeah, thanks for the question. Just to maybe set the stage a bit, I'll let the audience know that we currently have teams working in 4 different project locations throughout northeast Syria. One of them is a dedicated COVID response team, and then others are incorporating COVID activities in varying extents to their pre-existing programs, which we're addressing everything from preventative vaccination all the way up to secondary healthcare. And so I'll come a bit to the Yarubiya border crossing, or allude to it at least, but I do want to talk about some main challenges that our teams are seeing on the ground. So as a result of the Northeast being an area governed by a non-state actor, as mentioned, what we've seen is that there's not the same level of support in this area from the UN and WHO as other parts of Syria, and extremely limited access in PCR testing, PPE supplies, and other medical supplies. So the test positivity rate of around 45% in this region indicates a very narrow testing strategy, but that's directly linked to not having enough tests and having to prioritize who does get one. There's alternative solutions to try and overcome these gaps created by the political barriers, and that being one of the Yarubiya border crossing that you mentioned, but it's really difficult. And the end story is at this time that supply lines are inadequate and unreliable. Another challenge that we're seeing is related to the limited availability of healthcare staff. And so as mentioned already, extremely low levels or ratios of healthcare workers to the population compared to what is considered a minimum standard globally. And then we see high infection rates among healthcare workers that limits that workforce even further. And those high infection rates have led to restrictions in the Northeast of healthcare workers only being allowed to work in one facility, which from an infection prevention control perspective is very logical, but it's highlighted further the limitations created by the lack of healthcare workers in the region, especially specialist staff, and then also the need for continued support from international medical staff to fill these gaps during this period. Our teams are also seeing challenges as we expect in maintaining essential non-COVID health-related services. So we've seen waves of health facilities closing related to the staff infections, but also to the international organizations departing the region when the cases started to increase. And as an example, I want to give in Al-Hol camp where we work, we saw the majority of actors either scale down or close completely in the months of August and September, leaving the only doctors remaining in the camp, which has 65,000 people, being those who were part of the MSF team working in an inpatient nutrition center. And so it says a lot about the access to healthcare services when you're treating gunshot wounds in a hospital for malnourished children. And during that time, we treated over 800 patients with urgent non-malnutrition related needs, and saw a significant number of people coming to us to, in particular, for refilling their NCD medications, including insulin. The last and really important point that I want to raise for the challenges is related to the high case fatality rate we're seeing in the COVID treatment centers. So this includes the one that we're supporting, where we have a 34% case fatality rate. And we ask ourselves, why is this so high? And beyond the obvious reasons of the lack of ICU capacity, what we've seen is that the COVID treatment centers in the region were only accepting patients with positive results. And those with suspect illness are tested, and then they're sent home to await their results, although clinically they require admission into a facility. And by the time the results are received, those patients have already deteriorated into a very critical clinical condition. And so as a result, our teams have focused on opening suspect treatment wards to make sure that people who require care while they wait their test results have access to that care. But then we have another problem in that we see high mortality rates among the suspect and the negative patients as well, at around 16%, and an average of about 11 days between symptom onset and people looking to come for care. And what we think is happening is a bit of a cycle. So you have these high case fatality rates due to late arrival to a facility, and then that leads to the stigma around the illness and fear of the treatment centers themselves, which then perpetuates the late health-seeking behavior, and we full circle back to the high case fatality rates. And so here we really see the importance of community engagement, but also implementing a person or a family community-centered approach as essential, and this still needs a lot of work in the region. And I just want to take another minute to mention what's gone relatively well, because I think that's important. So the first thing that we've seen from the onset is that NGOs, and more importantly, the health authorities in the region, having a really strong willingness to engage, to align strategy, and to work together. And early on, we saw some actors who couldn't continue their regular non-health programming related to the restrictions that were put in place with COVID, shifting gears and trying to do things like health promotion and hygiene kit distribution with those teams, and that the donors allowed for that shift to occur, which was very positive. And then the last thing that I can't not mention is something that we've seen in Northeast Syria since we started working there in 2012 is the continued dedication and determination of the local health workforce. It's impressive after all they've been through, and I will stop there.
Thank you very much, Crystal. And that last sentence resonates, I think, with everyone on this call, and I am sure the wider community. Syrian healthcare workers have been incredibly resilient, and the COVID-19 has just been another assault among a number in the last few years. Dr. Nasser, I'd like to direct my next question to you. So you've been working on the EWARN surveillance for some years now, and I know that you've been responding with the team on the COVID-19 surveillance and public health response. Could you tell us a little bit about your work and also what challenges you are facing?
Thank you, Ola, and thanks for MSF for allowing us to share some of our experience about the Syrian situation. Yeah, and indeed, yes, EWARN have been implementing the surveillance-related activities and the lab testing with the COVID, and this is based on our previous experiences, 2013, with surveillance-related issues and our ability to detect multiple outbreaks in all the non-governmental health areas all over Syria, not just in the northwest, but northeast and even the south in previous times, and the ability to detect polio outbreak twice in that area in Deir ez-Zor. And based on that experience, we had already at the basis for respiratory illness surveillance system. So what we did since the beginning of the cases in Wuhan and the global fear that there will be further spread, we started to modify our system to cope with the situation, looking at the guidelines, development materials for training, etc., and looking for commercial kits, which were non-existent at that time. Only the labs with high capacity had the ability to test for COVID cases. So during that time, WHO office in Gaziantep and the health cluster started a task force. And in that task force, we were in charge of both the surveillance and the lab pillars. At the beginning, we had only one lab with one PCR machine, and we trained only one member for the testing. And from that, we started with a capacity of almost an average of 100 tests per day. Now we exceeded the 1,000 after expansion the lab network to 3 labs in Northwest. Although we had a late introduction of the virus at that time because of the situation that Dr. Fouad mentioned about the fragmentation and the multiple controlling forces, Northwest Syria has been somehow isolated after the international closure of the borders between Syria and Turkey. The crossing for population was minimal at that time. And the population were cornered in one area in Idlib mainly and some parts of northern Aleppo. But after the release of some of the restriction, the virus is there. And unfortunately, after a slow start at the beginning, we managed to contain the first cluster that happened, again, unfortunately, within the healthcare system. The more clusters started to pop up here and there, and we shifted to community transmission, unfortunately, at that time. At the moment, we are having, as in Northeast, a high positivity ratio, more than 35%. At days, it's 40%, although we managed to expand the sampling capacity to more than 1,000 or 1,500 even samples per day. Yet this is a high positivity rate, which suggests that there's higher circulation in the area, and the stigma that Kristen mentioned is there. People would fear to mention that they have any kind of symptoms out of fearing to go to isolation center, to have to stay at home isolated, or for workers because they depend on working on a daily basis to earn their living. And the healthcare providers are not also excluded from this, although all NGOs working in the area are stressing on the importance of IPC and the PPE measures, but still we had a high ratio of healthcare providers infected, but it dropped from 30% at the beginning to almost 60% now, yet 11% are direct healthcare providers, doctors, nurses, and technicians working at the health facilities. So this is high percentage considerably. And this suggests also that it's not enough just to go with the IPC and the PPE at the health facility level. There's a circulation in the community. So protection should be implemented on a wider scale, although it's really very difficult to advocate for a physical distance and for partial lockdowns or a huge curfew in this situation because it is highly concentrated areas. We have the camps that we started to notice increase in the cases in the camps as of the last few weeks. It's very difficult. And added to the fragmentation of the controlling forces, we have fragmentation also of the healthcare services themselves because it follows the NGOs somehow supporting it. So this is an overview of the situation. And back to you. I hope that we can discuss more into details. Thanks.
Cool. Thank you very much, Dr. Nasser. The E1 team and the other NGOs responding to the area are doing a fantastic job, but we can already see that the health system is very overwhelmed by what's happening. And that leads us on very nicely to Manar. So you've been doing some modelling both on Northwest Syria and Northeast Syria of cases, and you've been working with Dr. Nasser and others on this. Could you tell us a little bit about this work and perhaps what challenges that you have faced? And I know you've sent some slides, so I'm going to share them just now.
Thank you very much, Ala. So before answering your question, just to give a background about our work on modeling. So in May 2020, this year, we established a modeling team in the northwest of Syria, including local policymakers, healthcare professionals, and NGOs representative. And we used a COMO model developed by the University of Oxford, as you mentioned before, and participatory approach with continuous collaboration with policymakers over the course of the modeling process. So as you see, we have modeled 4 scenarios for different level of coverage for non-pharmaceutical interventions. We selected by policymakers. Scenario 1, the baseline current situation without changing any measures. Then we set scenarios with different low coverage of non-pharmaceutical interventions and mid coverage and high coverage. I think just to key findings we found is that introducing high coverage of non-pharmaceutical interventions is expected to decrease the burden of overstretched health system that's functioning already on 50% of its capacity. Introducing a moderate and high coverage combination of non-pharmaceutical interventions like hand washing, physical distancing, face masks, school closure are expected to decrease the hospital occupancy and avert COVID-19 attributable death by 60% and 90%. I think regarding school closure, although the modeling showed that introducing school closure for a long period would avert COVID-19 attributable death, but I think it's very important in emergency setting that we think about other impact that will have on children. I mean, we're talking about situation where there is a huge, there is big number of child soldier, domestic violence, if children don't go to school. So I think it's very important when modeling to think about this aspect. Other interventions that, such as shielding, self-isolation, quarantine, it's very important to be carefully designed, because what we saw in the North was that people there hesitant to go to the isolation center, and it resulted in increase of underreporting of COVID-19 death due to the not good quality of services, and at the same time increasing the coverage of some interventions that they are low risk, such as hand washing. They have let's say double impact in reducing COVID-19, but also it has positive unintended consequences on other infectious disease, which is more likely in such scenarios. Lastly, policymakers, it's important to make the best use of COVID-19 donation, because now donors are interested in this fancy disease. So I think to think about building the health system. What was interesting in the Northwest, that they are trying to local policymaker to push into like more ICU beds, and that will be good for later on for other disease. So I think that's important. So just very quickly, I'll highlight the key challenges. I think it was very important to use the COVID-19 modeling as a lens to understand the health system in the Northwest. So I think first, the fragmentation of health governance and decision making. It was very obvious from the early discussion about the parameters even of the model, because we wanted to think what are the scenarios that could work in the northwest of Syria, and then we had to think about who is able to enforce these measures, who is able to implement it. And we ended up with a map of over 10 policymakers. And I think, and then no one is able to enforce these decisions. So I think that was like a very good hint for the this empowerment of decision making. The second thing is this empowerment of local health actors. I mean, what was very interesting to see that when we were presenting our findings for local authorities, they were always referring us for INGOs or external donors to share the findings, because they don't have any power to enforce any decision, even if they are interested in or it's suitable for their context. The last thing, the prioritization of no-cost interventions, such as school closure. It was very obvious that now the COVID-19 cases increase, directly policymakers choose school closure as the key intervention, because I think they are because of the fragmentation of the policy making decision, because of the lack of funding, resource allocation. Although I think they are not seeing that the school closure could have high price on the development, overall development, and like future cost for the country, rather than seeing now the small impact and focusing on other interventions could have less risk on and harmful risk. Thank you very much.
Cool. Thank you very much, Manar. And one of the reasons and one of the things that we wanted to bring out of the panel today is also its applicability to other areas. And I think a lot of the things that you have just mentioned about governance, about disempowering local authorities, I'm sure will resonate with those working in other contexts. We've spoken a little bit about the Northeast and the Northwest, and of course the modelling that Dr. Manar, Manar and Dr. Nasser and others have been doing in the Northwest of Syria. And I know that you're about to begin a programme for Northeast Syria. What I would like to do is speak a little bit about what's happening in areas under government control and also what the role of the WHO is. So Dr. Fouad, can I direct a question to you around areas under government control, but also the role of the WHO in the COVID-19 response?
Yeah, thank you, Ola, and thank you for this question. This is an opportunity to bring also the question of politics and political determinants, for the health domain. And just look to the numbers. When we have, according to Johns Hopkins, and even the WHO, number of cases confirmed, laboratory confirmed cases now in Syria is 6,900. So that's the total, number, with the death around like 350. If you just check the numbers in the surrounding, in the neighboring countries, like 500,000 in Turkey and Iraq, like 200,000 in Jordan, like 110,000 in Lebanon, the smallest country among this. You can, the big question in this case, how come Syria is only 6,900? And that brings actually two issues. One is about the information, the data available from such a sort of political regime, which is, something very big. Second is what is the role of, different UN agencies. That's the only agencies allowed to work in this regime area to bring the issue of transparency and the issue, not to say accountability, about this part. So this is the main issue. We know now, from our personal connections, from talking, even UN reports, actually WHO report in late October, they have in their report talking about, they have unofficial information, which is quite strange, term, talking about the, increased number in such area and increased death, but they don't have any confirmation about that. So we know from our personal connection that, thousands and thousands of people with symptoms like, COVID, with a sort of a death among, in one day, in one day in Aleppo, my home city, in one day, 5 Syrian doctors, died because of 5 doctors in one day. The total number was in October among doctors themselves over like 100 doctors. So we're talking about numbers and big numbers. So the question is, what does it mean, this weaponization of healthcare? And I will bring this term again, not as sort of direct targeting with an arms, the health facilities and health doctors, but also to deprive actually the services itself from, being offered to the population and health system. So again, still this term of weaponization of healthcare is valid, even though we're not talking now about, an armed conflict, or we're talking about, shelling or bombing, hospitals or arresting doctors. By doing such a sort of behavior, I think this is also another way of attacking people, attacking their service. And you asked me the difficult question about the role of WHO. So my question is, to myself, but also to the international communities, including UN agencies, and if they have this unofficial information, if they have this unofficial, reports, so how to deal with that in a sort of, protecting people's health, and then in this term of sovereignty, when talking about they cannot engage because of the, sovereignty or the national sovereignty of a. But what about those who are, under, the control of this power? And this is important to raise. I know we're in a very health conference. We're talking about, we need to talk about health, and we talk about health, but we cannot disconnect, the politics, the economy, from talking about health, and I see it as sort of opportunity to bring that again to the discussion, and just to say at the end that we cannot address people's needs, people's health needs, without sometimes addressing, their political needs. And I will stop here. Thank you.
Fantastic. Thank you very much, Dr. Fouad. And I think it's really important when we do talk about health that we do touch on all the social determinants, because if the COVID-19 pandemic has shown us anything, it's just how important the interplay of these factors are. There are a number of questions that we have, but we are running short of time. But there are some really pertinent questions that I'd like to ask our panelists. So for Crystal, I'm going to give you two questions that intertwine, and I'll open that out to other panelists who'd like to answer. But we have a question here around, has there been some attention given to the mental health services and counselling, both of healthcare workers and the affected population? And also, and Manar might also be able to answer this, what are the unintended negative consequences of shielding activities specifically? So Crystal, perhaps if you start.
Yeah, thank you. And really good to bring up the mental health aspect as well. And I think, yes, it's extremely important in providing a holistic approach to the care of the patients that we're seeing, but not only those patients, but the families as well, and addressing those mental health needs. And that's things as basic as allowing visitors to come and see their loved one in the facilities, but also if that's not possible for some reason, distance, insecurity, whatnot, but providing means of communication through tablets. And so this we're really focusing on implementing, but the healthcare workers in particular is something that is also needs focus. And we see in particularly with those high case fatality or mortality rates in the COVID treatment centers, how important this is and how difficult that is for the staff that we work with to process that, when you're seeing 45% of the people or 35% of the people dying who come to your facility. So we have set up networks for counseling through telephone lines with professional counseling just for the staff that we work with, and that expands beyond MSF staff, but any partners that we collaborate with as well. Really important aspect. Thank you.
Thank you, Crystal. Manar, Manar, would you like to add a few words? And then I'd quite like Nasser also to add from his experiences as well.
Yeah. So yeah, just very quickly to answer the question about the shielding. I think I would say, like, now I think about unintended negative consequences would be like one, I think the mental health, because in Syria, typically elderly and vulnerable groups are taken care of by the family. So I think the idea of like shielding them when they are most vulnerable or having COVID, I think it may not be like well perceived by the communities. So it should be like very carefully designed. And then the other thing is underreporting. So if the quality of care provided for people in these facilities is less or worse than what they will think they would perceive at home, so I think they will be unlikely to report cases, and there will be hidden cases to avoid shielding. So I think that's very need to be carefully designed. Thank you.
Thank you, Manar. And Dr. Nasser, I'm aware now that so Fouad has mentioned there's been dozens probably of deaths in government areas. Sadly, in northwest Syria, there's now the deaths of, I think it's 4 doctors. Do you want to speak a little bit about the experiences of healthcare workers in the northwest?
Yeah, the death in general in northwest has been increasing recently. We've recorded more than 150, but we received the confirmation, the attribution of death for 95 of them, including, unfortunately, the healthcare providers. And that's why it's very important to protect them as much as possible. And that's why I mentioned the point of not just at the health facility level, but even at the community level, because scarcity of healthcare providers is a problem in all the areas. So this is very critical, and all NGOs and all the donors should put this in head, when they're trying to support things. And I want just to stress on one point that Dr. Fuad mentioned about the transparency of the information and what we really have in the field. And in a very small area with very limited resources in the Northwest, out of 45,000 conducted tests, we confirmed more than 13,000 cases. So it makes it more unlikely and unrealistic to say that only 6,000 cases are confirmed from the government area, with all the support that they are getting, with the high number of diagnostic tests, with labs, PCR machines, and etc. there. Thanks.
Thank you very much, Dr. Nasser. So I'm going to spend the next 20 seconds or so just summing up, because I know that we've overrun just a little bit. But as you can see, this is a very wide-reaching discussion about a very important topic. And so we thank you very much to our panelists. And if we're going to highlight some of the key points, it's about the fragmentation, the politicization of Syria's health system. It's the challenges of surveillance and public health response in a protracted conflict during a pandemic. And also something that's so pertinent is the impact on healthcare workers who are doing a fantastic job under the most tremendously difficult of circumstances. So thank you very much to our panelists and also for MSF India for allowing us to run this session.
Thank you. Thank you all.
Thank you.
Thank you everyone for joining us, and thank you Dr. Ola for moderating this wonderful session and highlighting some of the most important points about and experiences of healthcare workers in Syria. Thank you.